Video 5, Tic Disorders and Psychiatric Comorbidities. Other psychiatric conditions are frequently associated with tic disorders. Between 80 to 90% of patients with tic disorders have one or more comorbid psychiatric disorders. The most common psychiatric comorbidities include ADHD and obsessive-compulsive disorder, as well as anxiety and mood disorders, and disruptive and self-injurious behavior. In many patients, treatment of comorbid psychiatric conditions may actually take precedence over tic symptoms, as the functional impairment caused by comorbid disorders may have a more significant clinical impact on the overall quality of life. Tic disorders and ADHD, this is a very common comorbidity. And it's especially noteworthy that it can be more strongly associated with functional impairment. Severe tics can interfere with attention and concentration, while anxiety related to tics and premonitory urges can be very distracting and may also present as fidgetiness commonly seen in ADHD. Comorbid ADHD is likely to attenuate overall decreases in tic symptom severity. That being said, behavior therapy is still very beneficial for youth with ADHD and tics and is something we'll discuss in more detail soon. The alpha-2 agonists, clonidine and guanfacine, are recommended as first-line pharmacological treatment for combined ADHD and tics. Guanfacine is generally preferred since it causes less sedation than clonidine and it's not associated with rebound hypertension following medication withdrawal as clonidine is. That being said, as we've discussed before, the stimulant medications are so powerfully effective in ADHD overall, have such a benign side effect profile for most patients, and more recent data suggests that this does not aggravate tics and may help both tics and ADHD behaviors. So this is an important area to consider, that the alpha-2 agonist can be very much indicated in this population, but don't rule out the stimulants. And sometimes the combination of an alpha-2 agonist with a stimulant can be highly effective for treating comorbid ADHD and tics. Atomoxetina is another effective non-stimulant that has been identified as a useful treatment to reduce ADHD symptoms without worsening tic symptoms. However, this medication does not appear to have any anti-tic effects. That is, it's not going to decrease tics, but it doesn't appear to increase tic symptoms. Tic disorders and obsessive-compulsive disorder. This is referred to as tic-related obsessive-compulsive disorder and has important prognostic significance since there is a decreased response rate to SSRIs, which has been noted in youth with OCD and comorbid tic disorders. So children and adolescents who have OCD alone have a much better response to SSRIs alone than do patients with comorbid tics. The CBT, cognitive behavioral therapy, is considered first-line treatment of OCD in individuals with tic disorders. Exposure and response prevention is another effective intervention for treating pediatric OCD, and which has some preliminary evidence to support its use for tic disorders as well. For children with OCD and tic disorder, or where it's difficult to distinguish between tics and compulsions, ERP or a combination of exposure response prevention plus habit reversal therapy may target the greatest number of symptoms. And given the poor response to SSRIs, clinicians may need to consider clomipramine augmentation for obsessive-compulsive disorder treatment. Clomipramine has demonstrated superior efficacy for OCD symptoms over SSRIs, but it is associated with a much less favorable adverse effect profile. And there's also exciting data that suggests that when the SSRI is combined with cognitive behavior therapy, that can be even better than cognitive behavior therapy alone in tic-related obsessive compulsive disorder. So there may be a role for SSRIs in tic-related OCD, but that role doesn't seem to be as a solo agent, but combined with cognitive behavior therapy and non-medication treatment. That really is the treatment of choice. And if OCD is considered as the primary diagnosis or interfering with successful treatment, that is, unwilling to engage in competing responses due to associated obsessional content, treatment of OCD symptoms prior to engaging in further treatment for tics can also be an appropriate way to go. Tic disorders and anxiety or depression. Many youth with tic disorders have co-occurring mood and non-OCD anxiety disorders. If anxiety or depression appear to be primary, unrelated to tics, or interfere with treatment motivation and adherence, evidence-based treatment for anxiety or depression needs to be considered. The presence of depression in patients with tic disorders has been positively associated with an earlier onset, greater severity, and a longer duration of tics. Tic disorders and disruptive behaviors. Symptoms such as irritability, mood instability, problems with emotional regulation and anger control, impulse control, and other disruptive behaviors are very common in youth with tics. These symptoms often stem from tics and or tic impairment and can be managed by strategies that effectively address tics. However, other strategies such as parent training, anger management, emotion regulation, and mindfulness may also be required. If these strategies are ineffective, there are pharmacological interventions that can be helpful, including topiramate. Key points here. Decreased response rates to SSRIs have been observed in children with tic-related OCD. CBT with or without SSRI is considered first-line treatment in tic-related OCD. The presence of depression in patients with tic disorders is positively correlated with earlier onset, greater severity, and longer duration of tics. Irritability, mood instability, emotional dysregulation, and problems with impulse and anger control are common in youth with tic disorders.